in the next 40 minutes, we'll be talking about other important topics in cardiovascular disease. All right. You're getting a whirlwind today. So first, valvular disease, aortic stenosis, mitral regurgitation, very important. We'll talk about defibrillators for a minute or so, what to do when it's end of lifetime, congestive heart failure, and atrial fibrillation. Okay, so first we'll talk about the effects of aging on the valves, right? So what we see just from a pathophysiologic perspective is that the aortic valve develops increased collagen deposition and then thickening and calcification of that valve over time. The mitral valve gets some endocardial thickening on the atrial aspect of that valve, so that becomes a little bit of an issue there. The calcification of the mitral annulus, the circumference of the valve, is greater than in women than in men, and we tend to see more women going to surgery for mitral valve disease compared to men. There's some atheromatous changes that occur with lipid deposition in and around the valves, the aortic valve and mitral valve particularly. The tricuspid and pulmonic valve tend to be spared, so that's important. So mostly we'll be mentioning what are we going to do with our patients with aortic stenosis or mitral regurgitation. Those are the things that will happen in this age group. Normal aortic valve is nice and shiny, and there's no lumps or bumps or calcifications on it. But here, these are some bumps and thickening that happens to the calcified leaflets of the aortic valve over time. And we're going to talk in the next few minutes about how do we manage and treat valvular heart disease. Talking about the aortic valve, I'll never forget the patient who was getting some shortness of breath on exertion, and she was very fit and not overweight. She really did not have a lot of risk factors. Then I put her on a treadmill, which usually we don't put people on a treadmill, but clearly she only went a couple of minutes and then she got very short of breath, and her aortic valve was actually quite narrowed. And so it's important that we think about doing more evaluations in people with symptoms and the risk factors. So age is that risk factor. So a patient comes in with that shortness of breath or dizziness and fainting or near fainting. Often you don't realize it as a physician until you really try to test them, because they've already changed their lifestyle so that they don't walk very far. So make sure to ask how often they're walking, how far they're walking, and then their symptoms so that you don't miss the aortic stenosis. The murmur is pretty prominent. It's a harsh, late peaking systolic boom, boom, and it's once we hear that, then we know the patient needs an echo and further evaluation. Interestingly, when you listen or to the carotid arteries, there can be a delayed upstroke from the aortic stenosis, and the left ventricle can have a little bit of a heave if you put your hands on the ventricle, and there's something called an S4 gallop. So again, the aortic valve becomes thickened and non-mobile. So you get a lot of different things. And on average, when someone develops this aortic stenosis, the valve area declines by around 0.1 centimeters per year. So, after a couple of years, people will often require therapy. The factors that are more associated with rapid progression include being a male, smoking, diabetes, high blood pressure, elevated cholesterol. The median survival in patients with severe aortic stenosis, right, is once they've developed angina or fainting, it's only 2 to 3 years. And I've seen that throughout my career. And it's time to move and get something fixed before, they succumb to this aortic stenosis. 1 to 2 years after heart failure. So someone comes in and first they get chest pain, then they have, the angina, they faint. But once they get heart failure, then their prognosis, their survival is 1 to 2 years. So it really, there's a long asymptomatic stage, and then boom, the onset of symptoms, congestive heart failure, syncope, or angina all make, things to be the onset of those symptoms. If you operate on them right here, you can increase their survival. If you don't, then their survival is cut short, especially if they have heart failure. So the angina, they get up to 30 years, syncope, 27, heart failure. So it's important once you see these symptoms to really refer for therapy. What do we do? You can do in your office first, besides the clinical exam, the chest x-ray, an EKG, and then refer them for an echocardiogram to really define what the stenosis looks like, and then to a cardiac catheterization to make sure that the coronary arteries are okay, and then to talk about the treatments. All right. This is a picture of longitudinal aspect of the aortic valve right here, where it's open. And then we can't see it's not moving, so I can't give you the best parts of that. Treatment, first of all, you have to always remember about antibiotic prophylaxis. So people going for dental work, they've got aortic stenosis, they need to be pre-medicated. Medications to avoid. This is a type of person with hypertension. You don't want to give them too much of a vasodilator like an ACE inhibitor or ARB, because then they'll faint. So you don't want to do that. So you can use something like calcium channel blockers like amlodipine, but you often use in patients with aortic stenosis because it's not going to vasodilate them that much. So someone who has a reduced life expectancy. I'll never forget a lady, she was like, 87 at the time, but we really were only doing valvuloplasties, and she really wanted to spend time with her grandchildren and take walks in Central Park. And so we did this valvuloplasty, and she did beautifully. And it actually kept her active for a longer period of time. But basically, it's not a fix. So you go in with the catheter that has a big balloon on it, and you thread it right up into the aortic valve, and you dilate it, and boom, it opens up, and then you can have, an effective valve. Their risk is that you push it too much, and it then stays wide open. And we have a case of those where then it's a severe aortic valve regurgitation, and the patient goes to the operating room. So you have to be careful with the balloons these days. There are better options too. So the other thing is what we're doing more is the aortic valve replacement. So back to this is anyone who needs antibiotic prophylaxis, the prosthetic heart valves, history of endocarditis, congenital heart disease. So this is the improvement in survival once someone has had the balloon aortic valvuloplasty. And this would have been, this is with the aortic valve replacement. This is if they just had the balloon. So the survival rate's much higher if you actually treat with the surgical aortic valve replacement or the transcatheter aortic valve replacement, which we're doing more and more, right? So the traditional one, especially if someone has coronary artery disease, then you take them to the operating room and you do the surgical aortic valve replacement and you fix their coronary arteries at the same time, right? The transcatheter aortic valve replacement is much less invasive. It's considered a minimally invasive procedure. So with the transcatheter aortic valve, this is what the surgical replaced valve is, the bioprosthesis. Looks like that. The TAVR, or the transcatheter valve, looks like this. These are two different companies. This one's a little bit shorter, but basically in here is the material that will be the leaflets to the valve. And then the way it's transmitted is you either can go through the femoral artery down here, and guide your catheter all the way into the aorta in the cath lab, and then you put it right across where the part of the aortic valve is the widest, and then you inflate the balloon. And then you wait, and then you wait, you watch the pictures, then you do it a second time, and you expand with a balloon, and then you deploy this device, which is the aortic valve replacement. You slide that back in, and then that sits there, and you take your catheter out. Here you can do, if the patient has femoral arteries that are very narrowed, then you can go right to the into the aorta and go right into the apex of the heart directly and go backwards like that. And these are pictures of we're doing it in the cath lab. This is where the balloon is, and then they inflate the balloon, and then they deploy the actual. This is after they've deployed. Now this is the aorta, and this aortic valve placement is right there. People go home the next day. We've had some, within 24 hours. These were the initial two companies, and we've been doing them for years at Mount Sinai and all the major hospitals. Very, very effective treatment. So the improvement in baseline is important. The TAVR, it works. The outcomes are really have become as good as the surgical aortic valve surgery. The adverse effects are similar to surgery. So stroke can happen because if you're putting something into the aortic and there's a lot of calcium on that valve, the calcium can go up and cause a stroke. As the surgeon or the cardiologist is putting the catheter through, you can disrupt the area of your own internal pacemaker, requiring a need for a pacemaker. Again, some people need a temporary pacemaker, but it's rare that they come out needing a persistent pacemaker. You can have bleeding from the site in the femoral artery or in the chest. The stress can induce an acute MI. You can have some valve dysfunction. If you don't get a good seal of putting it right along the orifice for the aortic valve, you can get a leak. There are rare occasions where there's a problem and the patient has to go for urgent surgery. Perforation, tamponade, depth, infection are all, explained to the patient, but they're rare. What about the mitral valve, right? So now, after the aortic valve prosthesis worked very well and with minimally invasive transcatheter approaches, so that is also now being done in patients with mitral valve disease. So when we talk about patients with dilated left ventricles and congestive heart failure, and then the mitral annulus dilates, and then you get all this, you have this mitral regurgitation is causing that to dilate, and the patients are very short of breath, very ill. And so they've done studies looking at the COAP trial, which is a percutaneous treatment for the mitral valve. And they're getting better and better every year at doing these things percutaneously. So they looked at just giving medication or guideline-directed medical therapy alone versus the mitral clip and guideline-directed therapy. And this was a small study, but it really showed that those with moderate to severe MR and they had the mitral clip, it was safe. It provided a reduction in the mitral regurgitation. It reduced the rate of heart failure hospitalizations and improved survival, quality of life, and functional capacity. So the mitral clip was the first therapy that was shown to do this, and now there are other companies that have come out to do this. So it's really, really important for our older patients to know that there are minimally invasive procedures that can fix both valves. These are just some pictures. There's another way where there's like wide open, like these leaflets weren't co-opting well at all. There's a group that put these sutures in percutaneously through here and left these orifices open. That's a double orifice valve. We don't see to do that here in the United States. I think other places do it. Okay, So now there's another question about, this is seems to be out of the blue, but we're talking a little bit about heart failure, right? About like we're doing things like the aortic valve replacements and the mitral valve for people who have not only disorders in the valves, but they have the symptoms and they're short of breath, and so they get congestive heart failure. With that comes a risk of ventricular arrhythmias. So anyone who's had a myocardial infarction is at increased risk for having a ventricular arrhythmia leading to death, or patients with a dilated cardiomyopathy. It's another type of patient, or a patient having an acute event. So should we put an AICD in an 85-year-old? That's a question. So how old is too old? When should it be turned off? And so I think this is something that we think about as cardiologists with our colleagues in geriatrics, to talk about the goals of care before that becomes an issue. Because we definitely have put in devices in older patients, not based on their age, but based on their functional status. And then we have a very honest discussion about, if the patient then is near the end of life, when do we turn it off? It's very easy to put a magnet against the chest and deactivate the defibrillator. But it's something that anytime that we start the discussion about putting one in, then we need to talk about turning it off. So cardiologists have learned a lot from our colleagues in geriatrics and end-of-life care. Okay, so, and in fact, even the American Heart Association, American College of Cardiology recommendations say, so in patients who have heart failure with a history of a cardiac arrest, they were revived of ventricular fibrillation or ventricular tachycardia that is destabilizing their blood pressure. Or if they've had, they're at least 40 days post-heart attack and their ejection fraction is less than 30. And they're being treated with optimal therapy, and there's a reasonable expectation of a 1-year survival, they're recommending that that's a good time to put a defibrillator in. So again, that's where we've used your expertise in the palliative care world to be able to talk to families and patients about how to do this. And next of kin reported that clinicians discussed deactivating the defibrillator only 27 out of 100 cases, right? So this was earlier on in this use of the defibrillators, but we've become better as cardiologists of having those important discussions ahead of time, so that they should be able to choose to discontinue the therapy as death approaches, as they know that they're declining. So congestive heart failure, right? So now we have 3 types of congestive heart failure. The typical systolic heart failure, right? The heart failure with reduced ejection fraction. So if the number is less than 40% of ejection fraction, that's considered heart HFrEF, we abbreviate it. And then we have the diastolic heart failure, and that's the people we mentioned, but with the stiff heart, strong heart. So the ejection fraction is preserved. It's sometimes even greater than 50% because the left ventricle is very thickened, right? So you have longstanding hypertension, thickened heart, and the ejection fraction is normal, right? So that's also a subtype. So we have HFrEF, reduced EF, HFpEF, preserved EF, and then this one in the middle, mid-range, MRF, heart failure with middle reduced ejection fraction. So if the ejection fraction was in between the 41 and 49%. So that's sort of just in the mid-range, so we don't miss anybody about what we do. So there's 4 stages of congestive heart failure. And we're going to get into a different. Right. So I'm going to let's see if I can make this bigger. I don't think I can. Okay. All right. So stage 1 is what I wanted to say, is that it still can be asymptomatic. They can be a little bit of breathless, but really by stage 4 is when patients are really very tired, even when just sitting, walking to the bathroom is a chore, and they get very short of breath. So we have all the stages that we look at. Congestive heart failure is a clinical syndrome, right? And incidence goes up as we age. So around 20% of our patients over the age of 75 will have congestive heart failure. Importantly, in the United States, heart failure is the leading cause of hospitalization in patients older than 65 in the Western countries. What else happens? So as we age, why do we get congestive heart failure? As I mentioned before, the left ventricle gets a little bit more stiff, a little more thickened. The atrium dilate, especially if the patient has atrial fibrillation. So if the atrium is not contracting well and it's fibrillating, that increases the risk of heart failure because it's just not efficient. If patients have coronary artery disease, they're not getting as much oxygen to the heart muscle, that can make it weaker. Endothelial dysfunction results in cardiovascular disease. Heart failure. Myocardial fibrosis. We'll talk about amyloidosis in a few minutes. It's an important cause of congestive heart failure and something that we're seeing more and more as more treatments are coming out. And then again, another issue from the physiology of aging is, as we mentioned, the arteries become stiff. Endothelium does not work as well. There's some endothelial dysfunction, and we can lead to pulmonary hypertension as well. So we have the four traditional stages for stage A, B, C, and D. So stage A is people that are just at risk for heart failure. So those people who've had an MI, a heart attack, they've had a valve problem, their left ventricle is not healthy, or they have risk factors such as hypertension and coronary disease, they're at risk. They don't have heart failure yet. Stage B is the pre-heart failure. So they don't have many signs or symptoms, but when you look at their troponin levels with their BNP levels, right, the pro-brain natriuretic peptide level will go up with the beginnings of congestive heart failure, even when the patients aren't feeling it. So they might just be feeling weak and tired, and they've had some hypertension for years, and then you do a pro-BNP level and it's elevated. You can say, okay, they're really in the stages of heart failure, right? Could be preserved ejection fraction. And then when they really come in with symptoms and signs of shortness of breath, increased jugular vein distension, swelling of the legs, we are in stage C, symptomatic heart failure, and then advanced stage D, advanced heart failure. It was in the symptoms that interfere with daily life. Patients are in and out of hospitals. They can not do all of the physical activities that they used to do. So breathlessness. The other important thing I see, paroxysmal nocturnal dyspnea, right? So they're fine during the day. They get up in the middle of the night and they cannot breathe. Positional changes, they can't breathe, they can't exercise as well, wheezing, loss of appetite is important. And then don't forget confusion. So if you're not getting as much blood flow to your brain from your heart being weak, you can get confusion. Can lead to things like also syncope. What we look for in exam, and these are like important things, right? The elevated jugular venous pressure. Sometimes we hear a third heart sound or the gallop rhythm. If we push on their liver, we can look at your jugular vein. You can see the hepatojugular reflux, and that's very high. That's consistent with congestion, congestive heart failure. If you feel the apical impulse and it's not right under the left nipple, it's to the side, then you can say, aha, that's the heart is failing, it's enlarging. Look for ankle edema, like I mentioned, pleural effusions on exam or on x-ray. Tachypnea, tachycardia, so short of breath, breathing fast, heart rate fast, ascites. Okay, those are all clinical suggestive signs of congestive heart failure. And then we talked about, I mentioned briefly, the pro-brain natriuretic peptide. Interestingly, as we get older, right, the normal level, you have some wiggle room, can go up higher. It's because due to the stiffness of the heart, but not necessarily a newer pathology like true congestive heart failure. If a 50-year-old comes in and they're pro-BNP is 450, you can say, aha, there's something going on. They have congestive heart failure. 50 to 75 years old, they can go up to around 900. 75 years old, they can still be relatively healthy and have a very high level due to the diastolic dysfunction. So they might not have left ventricular dysfunction. They're squeezing in nicely, but they can't relax. And so it causes them to retain fluid and be short of breath. So again, sometimes it's not picked up. It's up to you, everyone here, to pay attention to the things before it becomes worse. I have seen this when someone comes in and the family says like that they're really tired and they're a little bit more confused. Again, they're not getting as much oxygen to the brain. Again, you have to listen to the heart and lungs and make sure you rule out or rule in congestive heart failure. Fatigue is also very common. So when I see an older patient who said, I've been very active all my life and now I can't walk across the room without getting tired, you need a cardiac evaluation and an echocardiogram to see what's going on. Sometimes you just hear some rails at the bases and that's enough to do an evaluation of what's really causing this congestive heart failure. And again, this, like I started to say, this pro-BNP level, it goes up aging. So it's not as sensitive a test as in someone who's in younger ages about the degree of congestive heart failure. Okay. So on echocardiogram, looking at left ventricular ejection fraction, like I said at the beginning, you can have preserved ejection fraction, you can have intermediate ejection fraction, or reduced. So HFpEF, HFmEF, HFrEF. On average, more of the heart failure patients tend to be female, which is not necessarily what I've seen in my practice, but this is what the books say. And they have preserved ejection fraction. So an older woman with hypertension as she ages, has some stiffness of the ventricle, comes in short of breath, but the EF is normal, ejection fraction is normal on echo, then it's the diastolic failure, we call it. This is other ways to identify besides echoes, which is the primary way to identify the different types of heart failure, is MRI, which is actually can look at filling pressures. That's usually done more in clinical trials than in daily looking. This is important. So cardiac amyloid, we've known about it for a long time. It starts off as heart failure with preserved ejection fraction or thickness of the left ventricle. Over time, it becomes reduced. The thickness of the left ventricle starts to weaken and it just dilates. People often think when they look at that first echo, it's confused with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is genetically inherited. It's common in more families. It's the thickness of the wall. It's like athletes who overwork their biceps. The biceps get bigger, right? So if you overwork the heart gets bigger, the muscle. What else do we see when we end up diagnosing them with cardiac amyloid? Interestingly, they tend to be on beta blockers. Their heart rate is low, but their cardiac output is low when we take them to the cath lab. When you treat them with ACE inhibitors or angiotensin receptor blockers, they often get significant low blood pressure. All right, so you have to be careful about the treatment. So there's two types of amyloidosis, maybe three actually, but the AL amyloidosis is from the bone marrow in the bloodstream, causes light chains and amyloid fibrils. This really affects the kidneys mostly. The transthyretin amyloidosis is particles coming from the liver, right? This molecule of transthyretin then can become dissociated and misfolded, causing these little amyloid fibrils that deposit in here, right here, in the heart, the kidneys, and sometimes even the gut. Importantly, look at this, carpal tunnel, and then in the sensory nerves in the legs. Okay, so importantly, So we have diagnosed people in the office that they come in and they have shortness of breath, fatigue, edema, arrhythmias, the kidney function's not doing well. And then they start complaining that they need a doctor for their new carpal tunnel, and then that they can't walk as well because they have tingling in their legs, right? Those patients have transthyretin systemic amyloidosis, right? So importantly, we can do a PYP scan of their heart to pick it up in their heart. There's other ways to scan the other parts of the body, and there's now medications, right? So when you look at the characteristics of the people in your office, these people come in short of breath and have a lot of complaints all the time, but you have to look at other things. So if they're over 80, it's a higher risk. 25% of people with this are diagnosed when they're over 80. They probably had it before that. It's just not diagnosed as well. In the hospitalized patients, you're calling a patient a HFpEF, heart failure with preserved ejection fraction. If their left ventricle wall is really greater than 12 millimeters, that's like a warning sign also. Think about amyloidosis. Men and women have equal incidence of having the amyloid. And again, lumbar stenosis, I didn't mention that. So clues, right? Especially bilateral carpal tunnel, but carpal tunnel and shortness of breath and lumbar stenosis, but not much neuropathy in their legs. You have to think about amyloid, the ATTR amyloid. Again, so this is the scan. So this is a negative scan. The heart's not lighting up. Here, this heart is all lighting up. It's a technetium 99 scan. So if you do that scan, you can make the diagnosis. Then you can do biopsies if necessary, but we usually don't have to do that anymore. The scan is usually enough. And there's the drug. So tafamidis is a medication now to treat the amyloid, cardiac amyloid. So it's important. The other important thing to note is that so people from the Caribbean islands tend to have a higher preponderance of this. So you look at your demographic of the patients who's coming in with these new symptoms, and you see where they're from, and you start asking questions about the other family members that they might have had some cardiac issues and some shortness of breath. Then you really have to put the pieces together. So this is the of the people who had amyloid and were not treated with medication. This is placebo arm over the course of 30 months. And those who were treated with tafamidis, if you see, like their change from baseline 6-minute walk was quite good. It declined to around 35% as opposed to 120. Like this is really a really remarkable improvement in their longevity and their quality of life. So it improves survival. It prevents the functional decline, improves quality of life, especially when it's given early. And then you need to detect it in their family members. For those who are caught too late, the people who are getting cardiac transplants, so it can really be effective. Let's see. Trying to see if I'm going to. Oh, yeah. This is a good just summary of things that we do for heart failure, right? So there's the 4 pillars of heart failure treatment, right? So there's different classes of medications. So these are the outcomes that have been looked at. So we talk about the ARNIs, right? The angiotensin receptor blockers. You can reduce the risk of hospitalization 42%. Beta blockers, right, can reduce death by 25%. Hospitalizations, the mineral corticoids, MRAs, reduce by 37%. That's cardiovascular death or hospitalization. And then this is the SGLT2 inhibitors, right? So importantly, we saw them come out for weight loss and found actually there's really good work with cardiac disease improvement, improves, it has a good effect on kidneys as well. So next. Um, so, um, you know, traditional heart failure medications included the ARBs, beta blockers, right? And then there came Entresto, which is actually combining neprilysin inhibition with an angiotensin receptor blocker, right? So that's Entresto. Now, this is several years ago, and I still don't see it, used as much in the office as in the past, but it was an important agent that came on the market that showed that it could really help get rid of some of the vasoactive peptides, and patients did much better with it. So we're getting close to the end. Atrial fibrillation, one of my favorites. I see patients every day in the office with new atrial fibrillation, right? And so we try to be the detectives and figure out what are the modifiable risk factors. Often it's a combination of a lot of things, and there is a genetic component with atrial fibrillation. So sometimes it's nothing with the patient, nothing that they could do. It's genetically inherited. But alcohol and tobacco, especially alcohol, people who are drinking more than 2 drinks per day have a higher risk of atrial fibrillation. And they found, actually, it was interesting. At first, we didn't realize that how strong that correlation was until they started doing ablations, right? So they go in with electrocautery and zap the area where the AFib is coming from. And then the patients would go home and they were fine. And then 3 months later, they're back in AFib and they're like, what the hell? So they did a big study here looking, what is it, why some people did fine and some people would have this recurrence even after a procedure. And it turned out that it was more than 2 or more glasses of alcohol definitely was a contributor for recurrent atrial fibrillation. So even when they went in and had the procedure and zapped the initial causative area, it was important. So now we really talk to every patient about doing that, especially before they do an ablation or treatment. So the other modifiable risk factors is exercise, moderate intensity aerobic exercise, more than 30 minutes a day, at least 3 to 5 days per week. We talk about that with all of us, with, healthy people, and we really find it's better for all of us to do this much exercise, and especially in patients with cardiac disease, including arrhythmias, which is AFib. Sleep apnea. I may have mentioned this at the beginning, that sleep apnea is now added as one of the 6 risk factors. So you just can imagine, though, people who have untreated sleep apnea, moderate to severe, when they're sleeping, their oxygen levels are dipping down. They're not getting good oxygen. They're not getting good rest. And so it's an increased risk for atrial fibrillation. Treating the sleep apnea with CPAP really helps. Weight loss helps for people who are overweight if they need to lose more than 10% of their weight. Or they have diabetes, to treat the hemoglobin A1C to less than 7, and target blood pressure less than 130/80. Interestingly, here is one of the few times they record exercise blood pressure of less than 200/100. Now that's pretty high. We usually don't even go that high necessarily on all our stress tests, but definitely want to keep it below that. ACE inhibitors or ARBs are very good drugs to help with that management. So you want to avoid stroke. That's the whole issue with AFib. We want to avoid stroke. So, and then there's that catch-22. The older patients are high risk for stroke, but we want to give them blood thinner, anticoagulation. They're also at higher risk for falls and other problems, or bleeds or GI bleeds. So usually we still want to give a true anticoagulant. And then sometime in the past, people were trying aspirin or clopidogrel if they couldn't give an anticoagulant, but it hasn't been as effective. And sometimes I think it's the patient that feels that they're protected with their aspirin, but they're not, right? So importantly is symptom detection, or detecting AFib using an Apple Watch or other device, right? I don't want to be prone to Apple, but they have a validated on the Apple Watch an algorithm that detects atrial fibrillation. And so it's been, I recommend it to many people. There's also devices you can buy at home. The cardio device, looks like a little bit of plastic, and then you put your fingers on it and it tells you what your heart rhythm is. So that's another thing. So people can detect if they're in AFib. I have patients who have had they've called me, my Apple Watch says I'm in AFib. What do I do? And I said, well, come and get an EKG, and they're in AFib, and we treat them, and now they have AFib. All right. So again, consider cardioversion. With the first episode, you can want to just get them out of it. But then you start to talk about, we do have great success with really taking them into the cath lab and doing an ablation and getting rid of the site that's causing the AFib. And again, this is this implantable loop recorder that goes in under the skin subcutaneously. It works for 3 years. And the study showed 28% incidence of new AFib. So it was important that, and this was given to people even after their ablation, that show that putting that little thing under their skin, then they don't have to have an Apple Watch. They don't have to use another device. This will notify them and their doctor when they happen to, if they have an episode of AFib. So, oh my gosh, we have 30 seconds left. Sorry, I took so much time, but it was a pleasure to be able to talk to you all today.
Thank you, Dr. McLaughlin. You do a whirlwind of review of these topics. So I have a few questions for you. I might not get to all of them. For those with aortic stenosis that are not candidates for surgery, are you recommending moving away from ACE inhibitors and probably using calcium channel blockers as an alternative if needed?
Yes. The risk of decreased blood flow to the brain, or orthostatic hypotension, is higher with the ACE and ARBs versus significant aortic stenosis.
Okay. Is there a median survival rate for early detection of AS without symptoms?
I would have to look that up. So clearly, once the patient most patients that are symptomatic, that's when their risk goes up. It's not like they're just, but unfortunately, right? So with all those comorbidities, if someone can't walk because of their hip and arthritis, and they're not walking very far to begin with, they might not having their symptoms that they would have had if they had were otherwise in good physical health.
That makes sense.
That's important to know in the general population, to be careful, to make sure you don't just count on those symptoms, but listen, and also, especially if they're not ambulating much.
Great. What is your choice of antihypertensive for patients with elevated systolic and low diastolic?
Oh, that's a good one. Okay. So low diastolic, but they have
a high systolic.
A high systolic, then a beta blocker. A beta blocker doesn't vasodilate. Like, you don't want something like an angiotensin receptor blocker, like an ARB or an ACE. They'll vasodilate them too much.
Okay.
So the beta blocker doesn't dilate them. Even the calcium channel blockers have more of a vasodilator effect, like amlodipine, So that would also not be my first choice, but a beta blocker
would be. Okay. And last question, can you discuss the use of prevent calculator that were recommended with 2025 ACC updates?
Yes. So I think it's been tested as being an effective calculator. I think if you can work it into your flow, I think it's very helpful, because there are some things that we don't necessarily ask the patients and don't write down or put into a calculation. But I do think the prevent calculator, it has been validated, is helpful.
Great. Well, I appreciate, and the participants appreciate, your presentations and your responses to the questions. Thank you very much, Dr. McLaughlin.
Always a pleasure. Thank you.
Thank you.
Glad to be here. Thank you.